Okay, so I wanted to welcome everyone for joining us on the Pain Exam podcast. Today, I'm honored to be joined by Amit Gulati, who is one of the WAPMU faculty, as well as the head of pain at Memorial Sloan Kettering. Welcome, Amit.
Thank you for having me. It's been wonderful to have a chance to work with you. Obviously, to see all the work you've been doing in this field has been great.
Thank you. So, Amit, could you just give us a little background about your training and your position currently?
Sure. I went to medical school in Houston, Texas at Baylor College of Medicine. I was fortunate enough to train at Emory University for anesthesiology, where one of my mentors, Michael Bias-Smith, introduced me to ultrasonography. At that time, it was just starting to assist us in helping us with regional anesthesia techniques. And so very fortunate to have his support and also Emory's support for giving me a good 6 months to try to do some research and learn how ultrasound would be helpful in doing some of these regional anesthesia techniques under its guidance. I continued forward under Sudhir Dewan at Cornell for the pain fellowship, and very fortunate to also have Tim Malhotra and Dr. Dewan as my program directors, kind of carry the idea of ultrasonography. Very fortunate to currently work at Memorial Sloan Kettering Cancer Center and bring technology of ultrasound to taking care of our cancer patients, both the guidance and now really with ultrasound therapeutics. So using some low intensity and high intensity ultrasound for therapeutic purposes on top of using guidance and thinking of new techniques to help with our cancer patients regarding their pain.
Sure. I found that with cancer, some people were just with the mindset, just throw all the opiates at them and just let them be. But of course, that's really not the end all be all when it comes to cancer pain. There's a lot more options with the ultrasound.
Oh, there's a lot more options in general, but you're right. I think, I think opioids have had a significant impact, positive impact for the oncology patient. Unfortunately, some of the things that opioids, part of using opioids chronically, opioid tolerance primarily, but even abuse and diversion happen in the oncologic population. I think that's really changed how we think about opioids, even for cancer patients, but also because oncologic patients are living a lot longer. So we're seeing those problems arise, whereas perhaps the 1 year or 5 year survival for most cancers was much lower 20, 30 years ago. Now we're much longer, and that's wonderful for us. But now you have to handle how opioids are managed in this population, just like you would in a chronic pain population.
Exactly. So you've become quite involved with WAPMU. You might just like letting us know how you got started and what you've been up to with the organization?
Sure. So World Academy of Pain Medicine originally was ultrasound, and now is United. It started with Scott Sarver and Michael Goldfeld a few years before I joined. So their original vision of WAPMU was to teach ultrasound as a device that can really enhance the delivery of pain medicine. So really to visualize structures, musculoskeletal, nerve, bony structures, to show the United States in the beginning and then the rest of the world that you can really use ultrasound to improve the delivery of pain medicine. I was very fortunate to meet this group. I want to say, I didn't even think about it, maybe circa 2012, 2013, somewhere around there, where I got to meet a group of people that were very like-minded. I hadn't happened to know Michael Goldfeld prior to WAPMU. And I just found a group of people at that time that were really interested in ultrasound guidance and really interested in really optimizing it. And I just happened to be doing the same thing on my own, probably similar to you are where you are at. And I found a group of people that really thought the same way. And so as I kind of joined the society and then our education commitments, slowly I kind of worked closer and closer together with Scott Sarver, Michael Goldfeld, those others obviously that are members of the society since the very beginning, Einar Ordestead at Stanford, et cetera. I think we've met a larger group of people, and you've seen how ultrasound has really impacted different fields of pain medicine. A wonderful example is regenerative medicine. Another example is peripheral nerve stimulation. There's aspects where ultrasound is very useful in optimizing delivery of certain therapeutics. And so as a result of that, the society has grown. I was, been fortunate to be president since 2019, and our outreach has become global as a result of a lot of hard work over since 2012, 2013, et cetera. And so we've changed our name to World Academy of Pain Medicine United because we realized ultrasound can be the foundation for a lot of different medical specialties. But the reality is that you have to deliver a continuum of pain medicine care, and we're able to teach that in conjunction with using ultrasound guided techniques.
Right. Yeah, I remember the first course I taught was a few months ago with you, and I didn't expect to see a C-arm there. And I remember you gave me the ultrasound and the C-arm. You're like, go to town, and I was like, all right. A little surprised, but that was great because I see now a more comprehensive educational experience for the interventional pain physician. And these technologies are definitely here to stay. I don't see them going away. So if you listen to the podcast, you know that I'm always advocating ultrasound therapy, guidance for injections, as well as fluoroscopy, of course, but depends what you're doing. So you're also trained fellows, right? And you have, I assume, residents rotating with you at Sloan. So being that it's a cancer hospital, do you get a lot of non-cancer pain there, or is everything mainly cancer pain, or is the cancer pain who happens to have a lumbar disc issue that you're taking care of?
No, it's very interesting that you say that. So probably in the beginning of my career, the cancer patient's primary active disease was causing the pain. Right. And that's still happening. What we've seen though over the years is that there are certain diseases that a great example is lung cancer. So, in 2007, when I started with lung cancer, one of the things I used to do was take an ultrasound device, take it to the floor, and anyone who had lung tumors on the pleura or on the rib, we do an intercostal nerve block and eventually a neurolysis. Now in 2021, a lot of lung cancer patients, their lung disease improved significantly with immunotherapy. So now you have patients who don't have nearly as many lung-related pain injuries unless it's metastatic already for some other cause. But now you have patients who are living 7 to 10 years who now had a pain doctor 10 years ago that helped with their pain, but now have knee or osteoarthritis. So what's really happened is we've grown because we don't stop taking care of the active cancer patients, but we also help with the chronic pain states that have occurred in cancer patients. And it may be occurring earlier because a lot of these patients during therapy aren't as active, they become weaker, more fatigued. That leads to a lot of musculoskeletal issues in general. Just by the fact that either you're not ambulating or you're ambulating incorrectly because of weakness or fatigue. So we're seeing a lot of chronic pain, quote unquote, because of longevity of a cancer patient. Some of it may be related, but maybe not directly. And so as a result, our practice is, at least my practice, probably has become 50-50 almost, where I was seeing chronic issues where finally I had to start learning the spinal stenosis algorithms a few years ago. I remember looking at this, asking Aaron Kolodny, I was like, I need to have your spinal stenosis algorithm. I never thought I need to relearn this stuff, but all of a sudden I need to figure out what to do, when to even consider mild procedures and interspinal spacers, where I never thought 5 years ago I'd even intend these things. All of a sudden I had to start planning for them because our patients have spinal stenosis, and I had a history of renal cell cancer 13 years ago.
That's right. Yeah. What year did you train? When was your fellowship?
I finished 2006, 2007.
Oh, just like me.
Yeah.
So back then it was, people were a lot freer with opiates, especially if someone had cancer. And I think two eye-opening cases I had when I just started as an attending was a patient with cancer with Mets to some of the meninges of the lower lumbar spine, and I wound up doing a spinal cord stimulator, and they did great because it was causing a radicular pain. And then another patient who came with Mets to I don't know if it was a peritoneum, it was more of the abdominal fascia, where there were these golf ball sized tumors, palpable, all over the belly wall, very painful. They were giving him opiates, couldn't control it. And I did a tap lock. Mm-hmm. And it practically cured his symptoms. A tap lock with steroid, it was crazy. So I think, in Brooklyn, I've gained a reputation amongst the patients and some of the referring doctors as someone who thinks outside the box. And the ultrasound enables you to do that. Because you can just apply all these anesthesia blocks that we learned in our anesthesia training and become so much more versatile. And then the regenerative stuff, plus the neuromodulation, I mean, the sky's the limit with what you could do to create a custom tailored solution to a patient's pain problem.
No, I think you're exactly right. I think technology has improved dramatically in the last 10 years in pain medicine. It probably was beforehand as well. Um, but the applications of it are endless for cancer patients, whereas probably in chronic pain, you probably see a majority of low back pain syndromes, neck pain syndromes, musculoskeletal, maybe certain joints. But oncology, you're still seeing uh, tumors in every location of the body, and you can really, really think about all the regional anesthesia techniques, physiatry techniques, even anesthesia-based techniques, and really come up with some clever ways of managing pain um, that hopefully doesn't necessitate all the neurolytics we used to do probably 15 years ago. So I probably have done many less neurolytic procedures outside of maybe the celiac plexus block. I think our other neurolytics are decreasing dramatically because of all neuromodulation and those kind of things.
When you guys were doing neurolysis at Sloan, were you mainly using phenol or alcohol or case dependent?
It's we're really dependent on alcohol. Until perhaps maybe last year, that's significantly easier to obtain. Um, and sometimes when you're making a decision to ablate, you may have made that decision 30 minutes prior to doing the actual ablation. And sometimes you make your decisions on ease of having equipment. And so for us, alcohol is significantly easier than phenol, which has to be compounded. But I can, and you'll see that throughout the world where people make decisions based on what's available. Um,
100%.
we have the ability to place intrathecal drug delivery pumps in a moment's notice. Almost, you could probably do it in a few hours or a day or two. And a stimulator I've done in 4 hours of meeting a patient, so I know it's achievable. So when you have that kind of resource, you'll make decisions differently than perhaps when you're in another country where those things are not available, whereas neurolytics may become more commonplace as a result.
Yeah. Speaking of, just remind me. Speaking of cancer pain and whatnot, I just received. When you every now and then, as a pain doctor, when you send someone for an MRI of their back or something, the radiologist calls you, and it's usually not a good sign. So, unfortunately, I have one of those difficult phone calls to make to his primary, a patient who has came in with radicular pain, but now it looks like he has multiple myeloma based on the imaging. So, it's never fun when you get those sorts of phone calls.
No, but the good news is you were able to discover it, right? The hardest thing is seeing
Yes.
chronic pain patients not getting the appropriate diagnosis. If the original injections aren't helping, that's when you investigate, because that's what we see. Because multiple myeloma can be controlled for many years. So you've done a great service for the patient.
Yeah. I've had a few times where patients tell you that you saved their life. One of the few times a pain doctor could save someone's life, I guess.
Well, I think as you realize pain is in almost every medical discipline, and as you get more and more patients that trust you, they come to you first because of pain, as opposed to going to their. I mean, I've diagnosed appendicitis and sent someone for surgery. So it's
Hey.
they have so I think you have appendicitis and you're urgent care, they get the surgery the next day or that evening. So I think as you become a little more seasoned, as a better word than older, you realize you're actually managing a lot of different pain syndromes that you perhaps didn't think about when you were first training.
Yeah. So I know you do a lot of peripheral neuromodulation. I wanted to discuss that. I guess in general, for the docs who aren't doing peripheral neuromodulation, is there something you'd like to say to them, or just talk about your experience with the product?
So yes, I think the field of peripheral nerve stimulation has significantly blossomed probably in the last, I want to say 4 to 6 years in terms of what's available and technology wise. So before then, it's always interesting to modulate a peripheral nerve. We've done that with acupuncture, TENS units. So these devices and the idea has been around for a very long time, but to have modular systems that are designed specifically to stimulate a peripheral nerve, as opposed to implanting a system such as a spinal cord stimulator to do the same exact thing, has really revolutionized what we can deliver to our patient population. Ultrasound happens to be a key guidance device or imaging device because it can visualize the peripheral nerve, or at least most peripheral nerves. So I think if you're going to be a practitioner, you're going to have ability to really fine tune neuromodulation. So if you're having a radiculopathy, a spinal cord stimulator or a dorsal root ganglion stimulator may be the best option, because that's where the the distribution of the pain is, that's where the ailment is occurring at. But for a lot of people, the peripheral nerve may be a much smaller distribution in your dermatomal pattern, or your pain pattern, and being able to stimulate and neuromodulate the peripheral nerve is very advantageous going forward. So I think as a young physician, you really want to think about how can I get my ultrasound guidance, imaging guidance, and anatomy improved so I can deliver these new and novel devices, which are probably going to continue to improve. You'll see some clever things coming out in the next 5-10 years, and they may be more commonplace as a technique for patient population.
Could you comment to the more experienced doctors with neuromodulation, or not just anyone, I guess, in general, what is probably one of the most exotic or less commonly placed peripheral nerve stimulators that you've done?
So that's a good question. Probably the ones we've talked the most to physicians who are starting their careers in peripheral nerve stimulation is we've done a few actually extraforaminal selective nerve roots, lumbar and thoracic, and probably even some low cervical. I think the brachial plexus has become a very uncommon target, has become a more common target. I tend to do it at the infraclavicular level.
Yeah.
But we do it for, oncologic disease, either related to radiation or actual tumors compressing the brachial plexus. Lumbar nerve roots tend to be easier for our population because we have a large sarcoma resections in the leg and the psoas. So really, you can't access the peripheral nerve easily. A lot of patients don't say want a spinal cord stimulator at 4 months of nerve injury, and so we find that temporary PNS devices are useful for this patient population targeting L2, L3 selective nerve roots. The fields are sometimes large enough where you might get stimulation of the dorsal ganglia, but that's all theoretical. So I never say we're stimulating the DRG.
Right.
But just some of the novel ones I've done. But if you go through our case log, we've done a number of different peripheral nerves, primarily related to the location of the cancer-related injury.
Sure. I've had some good success with the medial branch nerves. I recently did a C6 medial branch nerve block, and patient is very happy with that. She's been through the RFA, through trigger points, through pretty much everything. And yeah, pretty much everything you say I can identify with. It's really like, it's eye-opening. I have one guy who was getting facet joints for years, and the second I did the trial for the multifidus or the medial branch, he just got off the table and said, "That's the best thing you've ever done for me." And this was a guy who responded to 2 facet joints a year, and he was happy. So it's something else. And I think the idea of stimulating a nerve as opposed to ablating it is more attractive. You avoid that atrophy and all that. So it's a nice technique, and I think it's going to be used more and more.
Yeah, I agree with you. I think that ablations, when available to have neurostimulation, has been preferred for many patients. Again, this is case by case basis, and there are definitely patients that benefit from ablation over stimulation. But now they have a different philosophy of how to treat pain, similar to what we were doing prior to all this started, which was probably acupuncture. So, but they were using the muscle planes, fascia on top of or next to nerves for thousands of years for pain. I guess the difference was the temporary factor of acupuncture as
Sure.
opposed to in long-term improvement for many patients. But bringing back like I like to say, we're bringing back the bell bottoms. So, the ideas have always been there. The technology caught up to it.
Right. So before we wrap everything up, because I know you have to get to work, it's also nice to see someone up at 6 a.m. in the morning in New York as well.
It's a sign of age.
Right. And Scott Sarver couldn't be here, unfortunately, but we'll drag him on the podcast one of these days.
Sure.
I wanted to just recap on WAPMU, and I'm going to be collaborating with you guys, and just wanted to, I guess, get your idea of your vision for the future of WAPMU.
So my philosophical addition to World Academy of Pain Medicine United has really been to unify pain medicine with all the imaging modalities, all the therapeutics available. And our real focus for the next 2 years is to develop a comprehensive continuing education program in the various fields of medicine. Where we feel lacks is how people get their continuing education and maintain it for pain medicine. It tends to be very fragmented, really dependent on different societies to achieve it. And we feel that perhaps making modular courses in specific medical fields, and then able to update those things on a scale where social media exists. So instead of updating every 5 years your pathology of osteoarthritis and treatments for osteoarthritis, we want to do it in 6 months or a year, because that's the way the world works. The information travels that quickly, and the information is generated that quickly. We're in a world where there's a significant amount of changes in 1 year, and so we want to continue providing these kind of courses that allow physicians to understand the continuum of care for different pain syndromes, and that's kind of the focus of WAPMU, at least in the next few years.
Sure. And that's sort of what I think we have parallel goals, and it kind of worked out well that we connected, because I think Pain Exam and WAPMU's platforms are complementary. And with the upcoming course I have on March 14th for anesthesiologists, WAPMU is probably going to be a large part of that. And the course that we're going to hopefully do together in April 18th. All this, the April 18th is tentative with WAPMU, but we're hopefully going to work this out, and you'll hear from us on the newsletter. And hopefully it'll be a lot of fun, and it'll be a bunch of different instructors with different styles, not just me or not Amit, and we'll get to kind of bounce things off each other and figure out the best way to help our patients.
No, the beauty of WAPMU has been very inclusive, and really excited to have energetic teachers and innovators such as yourself. And because our philosophy has always been to kind of bring in the people who want to innovate, give everyone a platform to innovate within the society itself. There's really no, it's all about expansion of these teaching and goals, and you're providing that, which is a wonderful service to our community. And that's what WAPMU has always done. We've always brought in other people, yourself, who bring in some very different ideas. So we find, oh, that's a wonderful way to teach what we think would be an appropriate educational platform. So thank you for that, and I think it'd be a wonderful collaboration.
Thank you. And thank you for your time. Is there any closing remarks in terms of where people can find you, or more about WAPMU at which website?
Oh, sure. Our website is www.wapmu.org. I'm not a social media guy, so this is my first introduction to about myself. You're gonna, you can look up my band or something at punchforzero.com or something
Or they
like
can
that.
find you at the conferences once those.
Yeah. So hopefully you won't see me on Instagram or anything. I won't get messed up in trouble on Twitter.
Sure.
But I think if you're interested in the organization, there'll be a www.wapmu, or you can email us at, well, I actually don't even know what email to email us at. That's probably just email me, and then we'll be able to figure it out. But the society is like, yeah. But yes, if you're interested in the society organization, we are worldwide. Obviously, we had some changes due to the pandemic, so everyone is hopes safe and sound. But we'll be going back to our roots, which are really global educational platforms throughout the various colleagues we have around the world.
Great. Well, thank you for your time, and I'm looking forward to talking to more of the faculty at WAPMU.
Well, welcome to the team.
Thank you. Take care, Amit.
Bye-bye.